welcome everybody to this week's Miami Global Brain Tumor Symposium. I'm just going to go through a short introduction while we continue to wait for everybody to log on. I'd just like to thank everybody who made this possible today. A lot of administrators that helped behind the scenes, Ingrid Menendez, Roberto Suazo from the neurosurgery team, and Christina Tudolongo from the Cancer Center. We couldn't do this without you. I'd like to especially thank my co-directors, Dr. Komotar and Dr. Morcos, for helping me put this together as well, especially Dr. Morcos for giving such an excellent talk last week. We had over 750 participants last week, and the messages and thanks that we've gotten over the last week for his talk have just been outstanding. So thank you for the support for that. Just some housekeeping. So if anybody has any further questions about our symposium, you could follow us at Brain Miami on Twitter. We'll be giving updates to our symposium and who's coming next. Also, all of our videos are uploaded on our YouTube channel. You could search YouTube for Miami Global Brain Tumor Symposium and watch them at your convenience and a future date. If you have any other questions or want updates, you could follow either the University of Miami Neurosurgery Twitter, Instagram, or myself for that. And just, I know a lot of you won't be able to stay for the whole talk today, but just as a teaser for next week, we're going to have Dr. Schwartz come and talk to us about his many years experience with endoscopic pituitary surgery. Dr. Schwartz will join us from Cornell University. But let's talk about this week. So we have very lucky today to have panelists of junior skull-based faculty from all around the country who took time out of their week to help us with answering questions and making some discussion points during Dr. Spetzler's talk. We have Dr. Wang from UCLA, who's a pediatric cerebrovascular and skull-based specialist. Dr. Zacharia, who's the director of brain tumors and skull base at Penn State University. Dr. Benjamin, who's a brain tumor and skull base specialist here at University of Miami and our newest attending and recruit. We have Dr. Zenonos, who's the associate director for the Center of Skull Base Surgery at Pittsburgh, and Dr. Almefty, who's a brain tumor and skull base specialist from the Barrow. So thank you all for joining us today, and we look forward to your insight throughout today's talk. But of course, tonight we're all looking forward to hearing from Dr. Spetzler. He really doesn't need an introduction. He's probably the most recognized and world-renowned neurosurgeon in the world. And we're so lucky that he was able to speak with us tonight. He's the past chair of the Barrow and is really a master surgeon and super mentor, teacher, educator. He's really influenced everybody in neurosurgery in so many ways, whether it be directly with his teaching, indirectly with his talks, his lectures, papers, and just as a small, I mean, I'm sure everybody could find a way that they've been influenced by him. But just as a quick example, every one of the panelists or instructors in the course today have some lineage from one of his mentees or direct teachings from him. And that's, I'm sure we could all find that, but it just goes to show you how influential one person could be in the field. And we thank him for doing that. And we thank him for continuing to educate us and the world on neurosurgery, especially tonight's talk on complex approaches to difficult skull-based tumors. So with that, I'd like to turn it over to Dr. Spetzler.
Thank you. It's a pleasure to be here. I look forward to interacting with the panel, and I loved all those connections. I mean, this is an absolutely incredible field, and I am absolutely delighted to be participating today on one of my favorite topics. When we talk about skull-based surgery, I think we really sort of have to look at the evolution as well. And the evolution, for me personally, really is important to remember that the approach determines the exposure. And we all know that exposure is everything. I mean, if you can see what you're dealing with, you can take care of it. If it's invisible and you're poking around, you're going to do harm. So there are many different approaches to the skull base and different nomenclatures. Dr. Daspin and I did a lot of Trans-Petrosal approaches in the late 80s and early 90s and divided them into the transcochlear, which is the maximum bony resection, the translabyrinthian, and the retrolabyrinthian. And this could really be combined with any sort of other approach depending on the pathology we were dealing with.
Dr. Spetzler, let's if you could share your talk there with us.
So it's just a matter of really identifying the approach that gives you the exposure that you're interested in. And there are obviously a lot of them. There are different nomenclatures for them. And for the Trans-Petrosal approaches, those, I really did a large number of those in the latter 80s and early 90s. Gives you tremendous exposure. But I'm going to talk really about the evolution of how I've used less and less of those. And when we look at like the transcochlear and middle fossa, you really have a spectacular view of the brainstem and the skull base. So when we had a patient like this was a nurse from Tucson. She already had cranial nerve deficits. She went over to the other side. So what we did is we really did a Trans-Petrosal approach. So that was the craniotomy. And then my colleague Phil Daspin drilled out the petrosal bone. You can obviously see the jugular bulb here, the 7th cranial nerve here. This is the obvious tentorium going along here, sigmoid sinus. And so he's drilling this out here. I'm cutting the tentorium. I used to put clips on, but then I went really completely to bipolar because it was so much of a better exposure. But then you can really open here, the opening into the 5th nerve, and you see the basilar artery. You could see the vertebral artery junction. You see all the cranial nerves.
So let's just wait for Dr. Spetzler to join back in. George, do you want to share one of your cases while we wait?
Yeah, I'll be happy to. Let's see if I can make it work. Well, it's a quick case. This lady is a 37-year-old that had originally presented with a left 6th nerve palsy and had a lateral approach at another institution in another state. Unfortunately, this was complicated by a stroke in the left temporal lobe, and she had a kind of complete hospitalization. Per report, the tumor was very fibrous and bloody, and she recovered. She was observed for 5 years, and during this time, she started developing long tract signs, trigeminal neuropathy, vision loss. She had a stable 6th nerve palsy, but she had intact hearing, and that's where and when I met her. As you can see here, she has pretty substantial brainstem compression, but also she has bilateral involvement of the cavernous sinuses and Meckel's cave. And in the right lower slide, you see that there's compression of the optic nerves, and she presented again with bitemporal hymenopsia and optic neuropathy, as well as pituitary dysfunction. In addition to that, interestingly, she had a pretty substantial tumor blush on the angio, signifying a vascular tumor, but she also had like a persistent trigeminal artery supplying the some of the posterior circulation, and her left carotid artery was involved and stenosed, and although she passed her clinical balloon test occlusion, there was a moderate chance of a stroke on the perfusion. So I chose this case because obviously there's no perfect answer here. And I was wondering what the other panelists would think about this. How would they approach it?
Yeah, why don't you go back to some of the slides there, so and then we could kind of.
I think these are the most representative one.
Perfect, perfect. Dr. Almefty, you want to chime in?
Sure. This was a grade 1 tumor.
Correct. This was a grade 1 meningioma per pathology on the first resection that was done somewhere else. Yeah.
They received radiation.
She had not received radiation. They spoke about potentially radiating this, but she refused because she was getting more symptomatic. And also the radiation oncologist had sort of painted a very bad picture for the results of the radiation. So.
And the first surgery was a terional. Did I catch that?
The first surgery was an orbital actually. She had an anteroclinidectomy at the time as well.
Yeah. So, this is the circumstance is what makes this so challenging, beyond just being a sphenopetroclival meningioma, filling the cavernous sinus. It's now a redo case. And that carotid's almost certainly undissectable from this tumor. If I had first swing at this picture, I would probably do either a combined petrosal or anterior petrosal to it. I think in this setting, you kind of got to modify your goals. I think it's unrealistic to expect that you're going to resect that cavernous sinus tumor in this setting. So I think I would probably keep this one, hard to say without seeing a higher axial, but I think you can really get the brainstem decompressed and really the cisternal components of this tumor done well with a retrosigmoid, which would be probably the most straightforward for her. Now, if the circumstance was different, I'd probably do a bigger approach and really go after it.
Okay. Anybody else would do something different?
Yeah, I take somewhat of a similar tact. I think the two goals here, not being complete resection of this tumor, but decompressing the brainstem. And also, it sounds like one of the newer neurologic symptoms being this optic neuropathy. And so maybe taking a staged approach at getting the brainstem component, and then also the kind of the supracellular component, compressing the brainstem, and then probably refer her for radiation, external beam radiotherapy.
Yeah, from the audience here, we have a couple of responses. Kawasi approach, combined approach, transnasal and terional. But let's move on because I think Dr. Spetzler's back on here. Why don't you move through the rest of the case?
Okay, I will move quickly through it. Well, I really thought about a petrosal approach here, but given that it was very bloody to start with, I thought that maybe actually having a ventral corridor, a fresh corridor, may be reasonable for early devascularization. Also, to be able to decompress the optic nerves without disrupting the vasculature and the pituitary gland, and also will be medial to all the relevant nerves. And we were able to get a pretty reasonable outcome. Again, the part in the cavernous sinus, as you very well said, it wasn't something that we could deal with given the consistency of the tumor was very fibrous, and it was very bloody until actually we were able to devascularize it. Here you can see the approach, but we were able to decompress the brainstem and the optic nerves. And she actually did quite well. We put an EVDN that we removed for healing purposes, but both her ambulation, visual acuity, and pituitary function improved, but her trigeminal neuropathy and her left six did not. And now we're sort of discussing about potentially doing radiosurgery or involving radiation to the residual. That was it.
Okay, great. Very interesting. Thanks for being true to your Pittsburgh roots. Any panelist comments before we go back to Dr. Spetzler while he gets his slides back up?
Well, we'll try it again. I have absolutely no idea what happened. It just suddenly went black. Personally, I think it probably was shocked Morcos because he wanted to take credit for giving the best presentation. That's what I suspect. At any rate, this is a great case of a Trans-Petrosal approach. And the beauty of that, naturally, is that great tumor resection. but it makes it a big operation. There's the post-op. And so I want to show you the last transcochlear case I did, and that was really one, if I was faced with it again today and still operating, that's what I would still do. And that's a individual from Hawaii with this kind of a basilar artery aneurysm. And what you can appreciate on that is really that it has an entry and then keeps going and has an exit, so that there's really no basilar artery that allows you clipping of the neck of the aneurysm. So it is a daunting case, and for this, the transcochlear approach was really ideal. Not nice post-operative angiogram, and when we followed it up at 5 years, it remained the same. Obviously, there's going to be some thickening just because of the perforators there. However, my personal until they found this tumor. And there it's gone. And that's a very straightforward, simple approach. And here was an 8-year follow-up. So this is sort of the frequency of the combined petrosal and transcochlear approaches that you see here. And for petroglyval meningiomas, sort of the same thing. I mean, if you look at where these occurred, you can see we went combined approaches, and I'll show you something very similar to the case you just had presented. So you can see the Trans-Petrosal approach in the 80s, 90s, and then really disappearing for the very rare one like the last vascular I showed you. So this is a patient. See that the arteries inside the tumor. Fortunately, something you can never really tell for sure beforehand. This was a very soft tumor. It was bloody, but it was soft. So the first stage was nothing more than a simple OC approach. We were then left with this here. This is all gone, this is all gone, but this is what remains. Through a very simple retrosigmoid. The 6th cranial nerve. And you can see really this beautiful 6th cranial nerve, 7 and 8. And so this is what we achieved. You can see the pictures. And this is what we started up with, and this is what we ended up with. There's a little bit of tumor right in the cavernous sinus, which was then gamma knifed. And I think after about 6 years, I lost follow-up on her, but she did not have a recurrence at that point. So the question is always,
ask a couple questions here, the panelists, just because, especially because I think when the video is playing, it's a little bit crackled. But when you stage that kind of surgery, is there any precautions you do to make sure that the tumors is sectionally dry, or watch them more carefully in the interim while you wait for the next part?
Well, I love dry, and one of my favorite saying is dry, dry, dry. Right, Dr. Almefty? I see him smiling. He's heard that maybe too many times. Obviously, if you're going to leave tumor behind and it's a bloody tumor, your comment is very, very appropriate that you want to be doubly sure that it is dry. But this patient, as I recall, we went back either the next day or 2 days later, and it went fine. So here's another example where in the old days, we would have used the Petrosal approach. You can see along the tentorium, the tumor sneaking across and the symptoms. And what we did here really is simple retrosigmoid approach, taking out the tumor that was in the posterior fossa, see the cranial nerves. And again, no retractors in place. You see the 5th cranial nerve. And then we cut the tentorium from below. Obviously, the 4th cranial nerve is in the subarachnoid space, and you can see it here, and tethered to the tumor. And we slowly remove all that tumor until the only thing that's left, that's the 3rd nerve up above. The only thing that's really left is a tiny bit, again, in the cavernous sinus. You can see just a tiny bit of remnant right in here, but the volume of the tumor is gone. Just to demonstrate really how incredibly powerful the retrosigmoid approach is this is a 35-year-old cardiologist, had a brief loss of consciousness, and has this small blister aneurysm on the basilar artery. No retractor in place. We're coming right down, lower cranial nerve, 6th cranial nerve down below. And by just staying shallow with the retrosigmoid approach, we can go all the way down to the blister aneurysm. We see ICA coming off, and we see the aneurysm itself. Pre-op, and there's the post-op. It looked, and fortunately, this cardiologist made a complete recovery. And there's 3-year follow-up. You can see the clip right as we placed it. No recurrence of the aneurysm. Yeah, a lot of stuff was done in the lab. I took a lot of credit for other people's work. But far lateral approach, you really can combine these approaches all together with the Trans-Petrosal. But it really is a lot easier on the patient if you do a stage OC and retrosig, as far as I'm concerned, as opposed to a Trans-Petrosal. Far lateral, I've evolved a great deal as well. Instead of a hockey stick incision like this here that we used to do and published, actually a straight or little sinusoidal lateral incision prevents the muscle that we otherwise pull way over to get in the way and gives you a much shallower approach. And that really allows you to do that without retractors as well. So,
which the condyle is removed down to the 12th cranial nerve, and the vertebral artery is completely mobilized.
So I mean, it just
allowing exposure, greater exposure, and being able to reach the mid-basilar artery from this exposure.
So it really just depends on how much bone you take off as to how shallow your approach can be and what you're looking for. And I think the secret really from our skull-based society is that initially we took great pride in doing huge operations and pounding ourselves on the chest with what we've accomplished, with very little attention to all the little deficits we left our patients with. So opening, deciding what you can do and what you can't do is really key. When you look at a tumor like this, you think, well, that may very well be diffuse glioma that can't be removed, when in fact it has a beautiful edge, a beautiful differentiation between tumor and spinal cord and patella, and you can't really tell that until you try it. And here's the post-op. That's one that I shared with Ruth. Simple, the right approach. What we really want to do is the deep post-op, no residual tumor. Then they get a little larger, a little more difficult. Again, this is hard to see because I've never had better exposure of the basilar artery there. Would have been nice if we could have clipped something, but then we just sort of keep going. And there's the pre-op, there's the post-op, and the pre-op and the post-op. I think we probably should remind ourselves that just because the scan have used the far lateral approach. I've switched to the retrosigmoid approach only because it's tolerated so well. And for the upper medulla, you can easily get to that same location right here without going far lateral. And there's the post-op, and did very well. So the same thing sort of here that I've mentioned on the other one. Retrosigmoid has become really course, and this the patrols. So in conclusion, as I mentioned, said 1,000 times, exposure is everything. From a large and extensive to smaller but focused exposure. Better to remove bone than to retract the brainstem. I like to avoid retractors. Not that you should avoid them if you need them, but rather not put them in as a routine because that's the way you did it from the beginning. And for those that involve the lower cranial nerves, much better to be proactive with a tracheostomy and percutaneous feeding tube than chasing pneumonia left and right. So decreased use of petrosal and much greater use.
Thank you. I know that some of the video was a little bit difficult to hear, but I think we got a lot of it out of this. I just want to open it up to the panelists here for questions on kind of everything that was discussed.
Yeah, Mike and Dr. Spetzler, thank you so much for that. You know, I think that evolution to this kind of more tailored approach is so interesting. I'm just curious, kind of from an education standpoint, when as we start doing less and less of these truly complex approaches, it's almost this self-fulfilling prophecy where nobody's going to know how to do them, and you'll even more and more kind of support doing something like a retro sig. And I think that's how a lot of arts have gone. How do you kind of approach that from an education standpoint, or do you not think that's a big deal in terms of kind of the way your practice is shaped?
Yeah, you know, when I think back to when I was a resident, I would have so much loved to have courses like that are ubiquitous today. This ability to work on a cadaver and really learn your anatomy in that format as opposed to in the operating room is an incredible boon. And with 3D animation, with everything that's coming down with robotics, visualization, I think the resident that applies himself or herself during residency makes use of these incredible tools is certainly at the same place and better than we were when we graduated.
Yeah.
Dr. Spetzler, this is Anthony Wang. Thank you for that talk. I had a couple of questions for you, starting with when you kind of made the switch to approaching kind of those pontomedullary lesions through a retrosigmoid approach. Are there particular aspects of the preoperative evaluation, like where the jugular bulge sits and that sort of thing, that you pay close attention to in determining what's most appropriate?
Obviously, the jugular bulb can be a hindrance depending on what arrow what avenue you're entering. But for the upper medulla, it really isn't much of a problem because you're coming in below that.
And then kind of a follow-up question to that. In doing staged approaches and this sort of thing, are there particular aspects that you pay attention to in terms of setting yourself up for the next operation? Do you put anything in there to kind of like prevent scarring, or is there a specific timing that you like to use for that sort of thing?
Yeah, it's a very good point. Obviously, your timing is very much dependent on how the patient is doing. For example, it'd be pretty hard to take an angioblastoma and stage it. But for a meningioma, once you get it dry, like from above, if that patient is not any worse, looking good, I like to go earlier rather than later. So they are very sensitive to if the patient is sort of in that stage where you're not sure whether they're having problems or not. I never apologize for backing out of an operation, because I always tell the patient that's what I would want done. And I never apologize for not doing the next stage in a manner that I had suggested was possible, if at that point I feel that the patient benefits by a little more time. I think it's really that communication with the patient that is, and the family, that is very critical. I think they need to feel that what you're doing is always in their best interest. So in every case, I tell the patient it may take more than one operation, even though vast majority of time that doesn't happen. When it does happen, I tell them that's because if I do in 2 stages, the likelihood of you doing well are significantly better than if I kept going.
Dr. Spetzler, this is Carolina. Thank you very much. It was a great talk. My question is, in your tradition, when you are doing the Trans-Petrosal approach, what kind of preoperative, like imaging to look at the venous drainage, how do you evaluate that? Do you just use the MRI, or are you doing angiograms routinely, and trying to see the laterality of the transverse sigmoid junction as well as the entrance of Labet, and guiding sort of how easy your approach will be?
Yeah. Veins are absolutely critical. And there's no vein that I have more respect for than the vein of Labet. And the vein of Labet obviously enters the lateral sinus, although it can be very close to the sigmoid junction. And that is why the more bone you remove, the lower you cut the tentorium away from that junction, the less risk you have to the vein of Labbe. But the vein of Labbe, which really has 3 branches, it's an absolutely critical vein, and it should never ever be taken voluntarily.
Right. I've seen one of the tricks when you do cut the tentorium is to try to place your retractor, to cut it into 2 leaflets and place the retractor sort of on the posterior leaflet of the tentorium so that it elevates the temporal draining veins along with the temporal lobe as well as the tentorium to prevent stretch injury.
If in the rare, unusual case where you would have to place a retractor, that maneuver is absolutely the right one.
Okay, thank you.
Dr. Spetzler, thank you so much. Spectacular presentation as always. You have one of the largest experiences with operating on impossible things. And as you mentioned earlier, it's a very fine balance. Striking the exposure is everything, having just the right exposure, but also be very targeted into what you want to expose and avoid sort of this morbidity that comes with these huge exposures. And I guess 2 questions to that. How much, what would you advise, I guess, younger surgeons, such as most of us here, in terms of when they're starting out, try to get more exposure than you need, or try and try and experiment with just getting what you need, versus, and also how much does the pathology itself play into it? In other words, if you think that something is going to be challenging because of its fibrous or because maybe vascular, would you err in, having more exposure and that you may need, or do you, that doesn't really matter?
Yeah, we all practiced the pause before we started, which I think is a terrific thing. And what I've asked the residents to do after they finish a case is take another pause, and you look at what you have exposed, and you decide where you would like to have had more exposure, and equally important, what was not necessary. And by sort of doing that routinely, and you compare that to the pathology that you were treating, you will hone in your exposure appropriately. When I say exposure is everything, I do not mean large exposure. I mean targeted exposure. And the craniotomies have gotten smaller. The openings into the brainstem, are millimeters. These are all what I call targeted approaches. And naturally, without image guidance, for example, the intramedullary lesions would be impossible. But I'm very much a proponent of stopping when you're done and looking as how, if you had to do this exact case over again, would you modify what you did?
One question from the audience here is the role of raising the head during some of these skull-based surgeries, specifically sitting positions or whatnot. I know there's definitely a small cohort of people that really strongly believe for retrosigmoids, acoustics, that sometimes in the sitting position, it helps with venous. And this person is asking, what are your thoughts on that?
Yeah, Majid Sami, who is the most experienced neurosurgeon with acoustics, loves the sitting position and has done thousands of cases that way, and it's hard to argue with his results. For me personally, I did a few sitting positions when I was younger. I didn't like what it did to my neck. I didn't like what it did to my arm. When I was a resident, my chief resident lost a patient in the sitting position from an air embolus, and that had a memory that was hard to get rid of. So I don't use it. And then when you think about all the other operations we do, we're always operating where the bottom of the exposure is the most dependent. So we're used to using a sucker. I love the sucker that has a teardrop in it so that when you take your finger off, there's absolutely no suction at the end and are using it as a dissector. But for every other operation, that's what we do. So there's no reason in my mind why you shouldn't be doing that with the retrosig as well. And the proof of the pudding is that all those operations that I just showed you, and I can show you hundreds of retrosigmoid operations without a retractor. So if you don't need a retractor, you don't need the sitting position to get more retraction. And some of those sitting positions, when you look at the post-op CT scan or MRI scan and you see air everywhere, it is not without an additional small but definitive risk.
Right. We have a few minutes. Anthony, did you want to present your case?
Yeah, can do.
Mike, I think there was also a question about navigation when you use navigation, Dr. Spetzler, from the audience.
Very routinely for two reasons. One, even in your exposure, before you make your craniotomy, it may be of help. And if it is a routine, then it doesn't become something special when it's used infrequently and everybody's looking for the parts. So I used it a lot so that it became part of the normal setup.
Okay.
Okay. So can everybody see this?
Yes.
Yeah, we got it.
Okay, so this is a case that I thought was interesting, partially because of the considerations regarding the pathology. This is a case I did with my partner, Wang Kim, a few months ago. She's a young lady who had what amounted to a biopsy of a clival lesion done at another institution, and then the lesion rapidly progressed in size and in symptomatology, presented with severe ophthalmophoresis on the one side and neuropathic pain. I'm going to scroll through these images and just let me know if you want to go back and see more. But so you can see where the prior resection took place there. And so if I could just ask you to kind of help us think through this case like this. This is a normal chordoma on pathology, and she's symptomatic. She's not had radiation yet, and so my thought process was, here it's wrapped around the carotid artery. She failed a balloon test occlusion. What is going to be my most effective treatment, both in terms of her oncologic management and her symptomatic management?
Carolina, you want to take a go?
Sorry, can you scroll through again?
Yes.
And so you said this has been biopsied previously and has come back to be a chordoma?
That's right.
Well, I think you have to really think about this carefully. This is a young patient, and chordomas are obviously going to recur. So you want to really sort of, I think the first time is obviously the best time to really tackle this and try to get radiographically a gross total when possible. I know there's been a lot of thought about radiation if there's residual, and there's definitely controversy about the right timing to do radiation, but certainly there's a significant tumor burden here. So, I think for this patient, an endoscopic transclival approach would be a good way to get the majority of the tumor bulk. Scroll through one more time on the axials, please. Yeah, get you there low enough. And then one more time on the coronal. Yeah, certainly, you know, that's not going to get you the tumor that's lateral to the carotid. So you might be thinking about a combined approach for this patient. But I think I would start with getting the majority of this out through an endoscopic transclival approach, and then consider a second operation to get the tumor lateral. And the reason I think, you know, you should sort of aggressively try to get as much tumor out as possible is, again, it's chordoma, it's going to be coming back. She's 43, she's young. And I would try to avoid having to radiate her at the get-go.
Yeah, that was our first thought, but I would love to hear you know, a different view.
Yeah, I'd kind of take the same tact, try to get a more radical resection through an endoscopic transclival approach. But then I would favor upfront radiation and consideration for proton.
Yeah.
I also agree with Carolina. I think, I mean, I'm obviously very biased, but especially for chordomas, the epicenter where they start is you know, around the clivus, and therefore, you know, following the tumor from where it's coming, I think it's a very effective way to do it. In terms of their consistency, you know, even though they tend to involve the carinous sinus, they tend to be very soft tumors. So, and they're very suckable. And the majority of the time, as opposed to chondrosarcomas, they don't tend to invade the wall of the carotid artery. And in the institutional series here, you know, with multiple over about 300 chordomas, the vascular injuries happen with chondrosarcoma just from the nature of the disease. She hasn't been irradiated, so I think, you know, it always has to be a consideration. But I think the chance of a vascular injury it's much lower unless it's done iatrogenically. And I also think this goes quite low. It also goes in the intradurally in order to get as comprehensive margins as you can do. You're not going to be able to get complete margins, but just so that you don't have separated tumor everywhere and make everything in one field when indeed there is radiation that's administered, I think it's going to be easier.
I also think, you know, the molecular markers here, I think, are going to play out to be important in terms.
I completely agree. I think there are molecular panels now, like for chordomas specifically, that can guide the decision making whether someone can be observed versus they should be radiated up front.
I mean, this clearly, it sounds like, has already demonstrated progression over a short interval of time. This is going to be one, even with the radical resection, that's probably not going to want to be watched. But I agree that it doesn't hurt to get the molecular testing to see.
And I think the other thing too here is, I agree with everybody, is just understanding, you know, if you do have to go to a second approach, you know, which approach do you do first, and how does that implement your repair techniques? And so I think if you were to start transcranially here and then leave some and then have to come back endonasally, it would be a little bit harder to kind of do that repair. Whereas if you were to go transnasally and then come back to get that last part in Meckel's cave, you could do that kind of repair of the skull base and prevent a CSF leak a little bit easier transcranially coming back in the lateral approach if you left some in Meckel's cave or lateral to the carotid.
Dr. Spetzler, do you have any wisdom on this?
Well, unfortunately, I've seen too many of these, and I'm incredibly pessimistic about this one. I think, as Dr. Sontag would say, the cat is out of the barn. I think the first chance was the best, but even then, chordomas are incredibly difficult. I'm actually sort of a little bit surprised there was a chordoma, since it was more lateral rather than just midline. But give me a chondrosarcoma any day. I didn't realize that they had a greater risk of vascular injury, because I don't recall a vascular injury with those lesions. But I think this one debulking with the caveat in mind that she's 43 years old, she's going to die from this, and to make her as palatable of a life as possible.
Yeah. So I won't belabor this. Our first thought was to go endonasal first. I actually kind of changed our minds and went transcranial first to see how much we could get before opening up her dura, kind of her clival dura, and exposing her to that CSF leak risk. And so this was after the first operation. We kind of did a lateral loop slash Kawasi approach from above, and basically just stopped short of reaching across to the contralateral condyle. Was able to get it all off of the carotid, which is kind of my stopping point with regard to like how aggressive I was going to be. If I couldn't get it off of the carotid artery, then I wasn't going to push the issue. But got it out of the cavernous sinus, got it out of Meckel's cave, and was able to kind of patchwork reconstruct the dura on this side, and then we came back in through an endonasal approach and kind of took out the bottom part that we left to get her to radiation. So.
Right. And we have a few more minutes, so I have a case too here I could share.
Yeah, let's do it.
I'm going to go kind of just staying on the chordoma theme just for one. My cases are much shorter. But so this is an interesting presentation because it's more of a lateral presentation of a chordoma, but a 30-year-old female with kind of a more apex origin of a lesion. But it was, you could see here on the top left in Meckel's cave, and then down the petrous apex, down behind the petrous carotid, and then almost down to the jugular, just above jugular foramen here. Has some just mild double vision, but otherwise asymptomatic, first-time surgery, biopsy. Well, we didn't do a biopsy, but we found out intraoperatively it was chordoma. But, I think this is also kind of on the lines of which way would you go? What are your limits of approach? What do you guys think?
Well, I would go middle fossa, but I'm absolutely surprised that this is a chordoma. How sure are you of the pathology?
It was double checked.
Yeah, I mean, that really shouldn't be a chordoma.
I agree.
But yeah.
We were expecting chondrosarcoma just because of its being lateral and on the suture line.
Right.
George, would you go after this endoscopically? Oh, I think we lost him. Anybody else? Anything besides middle fossa?
I mean, it looks possible to me from an endoscopic approach, but I mean. Yeah,
it was. So we did a Kawasi on the left, and we had some difficulty after we came around the cochlea here, and the drill bit was kind of limited, and so that we couldn't get to the bottom on the bottom right here by the instruments, just by the angle going over the carotid and the cochlea. And so
to get that far low, that is one of the limitations of the Kawasis, right? I think I remember this.
Exactly. And so so what we did is
Nice.
So we came in there and we were able to actually bring in the ENT equipment, an endoscope and a curved drill that you use for kind of frontal sinus resection, and actually go around the corner and reach around. And you can see here's my screen is covered by your picture, so hold on a second. You can see here the IAC and where the inferior aspect of the drilling we were able to get to by using kind of an endoscope, 30-degree endoscope, and then using kind of the 90-degree drill around the corner, and the setup to kind of, as you know, the chordomas are pretty soft, and you're just trying to drill out that necrotic kind of tumor. And then this is kind of what the setup looked like while we were doing that. So we had our fellow holding the scope, I was drilling, and then another chief resident irrigating. And it actually was fairly comfortable to kind of work at that for about an hour to kind of get that last little bit around into the deep clivus. And that prevented us from having to go back endoscopically to kind of go out that lateral clival approach. So I thought that was really kind of pushing the limit, the inferior limit of the Kawasi. I don't know if anybody has any comments on that, how inferior you could go on the Kawasi, but that was as far as I've gone myself.
Yeah, I've actually had the same experience with the endoscope and in a chordoma, it opening up. The thing that's left in my mind is what Dr. Spetzler said, is this either isn't a chordoma or there should be a clival portion of it. And so, you know, what it was is what it was. But one note I would make is I would really study a thin cut CT, even post-operatively, and make sure there's not a small hole in the clivus that should be drilled out as well.
Yeah, excellent points. Yeah, I didn't believe it either until we sent Foundation 1 genetic testing, and all the kind of the mutations came back as well. But we're following it closely with GI radiation. We're following it closely. And then just one last case, just to hit back more maybe on the meningioma side point, just to kind of see what everybody's opinion now that we've heard Dr. Spetzler's talk. So these are the kind of cases that I think he was really focusing on, is petroclival or posterior petrous face meningioma. So here's a 52-year-old female. I call this one more of a left posterior petrous face meningioma because the fifth nerve was pushed medially in this case. I had hearing loss on the left, facial numbness and imbalance. Very strange in that the enhancement was kind of this different stages here. I wasn't sure if we were going to maybe find kissing tumors, but it ended up being all meningioma. But you know, the question of, you know, these tumors that go above the tentorium and they touch maybe the PCA or PCOM. You know, Dr. Spetzler showed a nice view of cutting through the tentorium. You know, is that what everybody else in the panels have been doing for these that kind of go a little bit above the tentorial edge here, or not?
For the questions, the origin, like you said, and you know, if the origin's lateral to the fifth nerve, and you can usually see it on a fiesta, how the tumor relates to Meckel's cave. If that's the case, like it looks like this one is, then I go retrosig, and usually that if you drill that petrous apex from the retrosig, you can get into that Meckel's cave and remove that portion of the tumor. Now, if its origin's medial on this tumor, I would use a petrosal approach.
Exactly. Anybody else have any thoughts? That's great. Those are great ideas.
Yeah, I think that in cases like this, I try to remind myself to pay really close attention to details and positioning, because your ability to look up is going to be, you know, severely kind of affected just by very small changes in the way that you position this case. I think the other consideration is that, you know, you're thinking it's a meningioma. If it's a grade 1 meningioma, like even if you leave a little bit, like she's got a lot of good options in front of her. So, yeah.
The thing to consider, Mike, is what you said her hearing was gone?
Yes.
Okay. So, you know, another thing that Dr. Spetzler was mentioning was really how you try to drill as much so you don't have to retract. So I think, you know, in somebody who you don't really need to preserve the labyrinth, then that gives you a little bit more options in terms of approach as well.
Good. I also agree that if the fifth nerve appears to be pushed medially on imaging, and this one seems to be starting quite lateral, I think a retrosig with suprameatal drilling will probably get you what you need.
I'm not sure how do you define being pushed medial? Because clearly when you look at where this tumor is in relationship to the basilar artery and to the brainstem, there's going to be tumor on both sides of the fifth nerve. It has to be. I mean, the tumor really surrounds the basilar artery with a small enhancing component. So I think that the whole secret of this one depends on the interface between the tumor and the arachnoid as to how aggressive you can be. But I would say a simple retrosigmoid approach. You can certainly take the labyrinth here to get a little more room since you've already lost your hearing. I think you should be able to reach all the way up to the very top at the very edge of your exposure.
Yeah, I think if I were to do this today, that's what I would have done. But this was a little bit earlier on, and I was being extra cautious and maximizing my exposure. So we actually did this in a staged approach where the first day we did a translab partial petrosectomy. And what we found is actually the tumor kind of necrosed. This is the kind of the MRI the first night after just the bony approach. And you can see that weirdly less enhancing area actually really necrosed, and it's almost non-enhancing anymore. And then that left us to go back the second day for a combined petrosal approach to remove the tumor. Ended up being a grade 2 atypical meningioma. And so in retrospect, I guess we were glad that we were aggressive with getting as much as we could out. But I agree with the audience and that, or the panelists, that I think if I were to go back, I think a lot of this could have been accomplished in a one-day surgery with a retrosigmoid suprameatal approach.
Mike, did you send the different portion, like you sent it all as one piece instead of trying to see if there was any?
No, we sent it as, I think it was 5 sections as we went through the different areas of the tumor.
Yeah. Interesting.
So are you going to radiate?
Yes. Well, yeah, so that's a great question. We should ask the panelists before I comment on that. What would everybody do?
Yeah, for this one, I would do adjuvant external beam radiation. I mean, it looks like there may be some very small residual left there in Meckel's cave, and with these, the risk of recurrence would be extraordinarily high. And for a young person, I think that makes sense.
Mike, the grade 2 determination was based on KI or it's a PL invasion, or?
It was based on KI.
You do condition 1 as well for this?
I believe so. I have to go back and look, but yeah, I think we did.
Toronto has some promising stuff to sort of try to predict which one of these will kind of recur. So that might be interesting to look at.
Kaith, would you radiate?
I think given what appears to be some residual there, I would probably wait maybe 2 months or so, and then possibly if I continue to think there's residual nodular enhancement, then yes.
And Kaith, how about you?
If there's residual and a grade 2, it should be radiated. If there's not any residual, I would enroll them in the ROTG trial. Grade 2 and plus or minus radiation, we don't know the answer to yet, but I think that trial is going to fail us as well, because they're lumping Simpson 1s and Simpson 3s and a lot of question marks. So I don't think we have the answer for this one. I probably would say go ahead and radiate it. If it was a convexity or something like that, I'd say probably not and save my radiation if I need it in the future.
So would your dad disown you with this particular answer?
He hasn't disowned me yet, so he's he's tolerant than he appears, I guess.
And you bring up a good question too, Kaith, is what is residual? Obviously the Simpson grade. Also, if you look at the initial papers, didn't count things like tumors in the sinus, whatnot. And so, when we have a clinical trial that talks about residual and Simpson grade, what do we actually call that? What have you guys been calling a residual? Okay.
I didn't catch the question. There was a breakup on the mic.
Oh, sure. So the question was, with the Simpson grades, there's the initial paper discounts some kinds of tumors. So like tumors in the sinus was still counted as a Simpson grade 1. And so when you talk about, is residual left, you know, what is really considered residual and what's not? Do you go based on what the MRI shows, or do you go based on, is it in the sinus, is it in the dura, whatnot?
Yeah, at least for that trial, the surgeon has to dictate that what their Simpson grade was, and then the MR has to be consistent with that report.
Yeah.
But yeah, to me, residual tumor, and wherever it is, it's residual tumor, whether it's in the sinus or frontal bone.
Yeah. To answer your question, like from my perspective, I would have a hard time ever calling a resection involving the cavernous sinus a Simpson grade 1.
Yeah, I agree. Okay, great. Well, I think that was a great discussion. I think a lot of the questions that the audience asked here, we've already answered, so I'm not going to go through them again. But I would like to just thank everybody again for their time. Especially, I know it's a tough time with COVID, so I hope everybody is staying safe with your colleagues and your family. And we look forward to seeing many of you back next week for another symposium.
A pleasure. Bye-bye.
Yeah, thank you so much. This is great.
Thank you very much.
Thanks for having me.